Okay.
I don't understand.
So today we're going to talk about insulin therapy for diabetes. Now, insulin would be primary therapy for people who have type 1 diabetes. I'm going to interrupt my presentation, though, by introducing a guest to our class. Many of you have probably already heard of him. His fame has probably preceded him. Holding Costanza, will you please stand up? You may be familiar with him from television.
Yeah, I know a few TV shows.
Okay, a few movies. He's had guest spots. He's usually way down there in the listings. Well, obviously people have heard of you, so take a seat.
Thank you.
He's never coming back.
Ruined.
Never. You have to
Hey,
have another heart murmur.
I thought his story went over well.
That was fake.
That was a real
It's
story.
not real.
We should have thought it was a broken heart, I'm telling you.
That was a real story.
Yeah, why did you
Is
keep
that it?
looking at Dr. Penner like he knew your story?
Well, because he told me.
As if Dr. Penner told you a story that was supposed to be your story. It's your story, so why are you telling Dr. Penner if it's your story?
We're both part of the story.
He wasn't
He
there.
played a major role in the story.
He gave
Well, I
He
gave
made
the
it
idea.
up.
I gave the idea.
We all start with an idea. And it's all
So,
something.
wait.
And I tell you, most of my ideas have worked.
What
That one
really
did
makes
not.
me think it's fake is that you're like, yeah, people were filming.
He did have. What happened was, he had told a
That's
friend
weird. That's
ahead
weird.
of time that's
That's
what they were
why
doing.
the girl was like, I gotta get out of here.
I'm
And
so
that may be the
confused.
case.
He had no idea.
I'm so confused.
Yeah, what are we talking about?
Don't worry about this. We
She
gotta
had
go
no
on.
idea.
Yeah.
on a date with someone.
He's gonna
It's just
feel it.
somebody who comes into the school and just disrupts everything. Don't worry about it.
Don't call anyone, just let it be.
All right, so today we're going to talk about insulin therapy. We said that insulin is the primary mode of therapy for people with type 1 diabetes. And there are many types of insulin that are available. They differ in their source. For instance, some pigs come from insulin. Insulin comes from pigs, porcine insulin. Traditionally, some has come from beef. Most of the insulins we use now are really derived from humans. Insulins vary in terms of time of onset, how quickly they kick in. And then they vary in terms of how long they last. For instance, some insulins are long-acting. You give one injection, they last the entire 24 hours. Some insulins are very short-acting. They're meant to cover just the period following a meal. Okay, those are called short-acting insulins. So we said that traditionally, insulin was obtained from pigs. It's called porcine insulin, or from cows. It was called beef insulin. But most insulin today is human insulin, and it's derived from DNA technology, recombinant DNA technology. Okay? Now, that natural insulin that's derived from humans can be modified by pharmaceutical companies. And it's the modification of insulin that causes variation in terms of how rapidly it kicks in and duration of action. Okay? The pharmaceutical companies can modify human insulin in two different ways. One way is by complexing the insulin, binding the insulin to a protein. Okay? So they take a natural insulin and they bind it to protein. For instance, NPH insulin, which is an intermediate insulin. It has an intermediate duration of action. That's formed by taking natural insulin derived from the human body and complexing it with a protein. So it gives it a longer duration of action. Other insulins, the molecules are simply modified by the pharmaceutical companies. Okay? So it creates what's called a human insulin analog. In other words, it's got a molecular structure very similar to that of human insulin. Two of the brand names, for instance, are Humalog and Novolog. These are analog insulins. They're derived from human insulin, but they're modified such that they are shorter acting.
Bless you.
Okay? So they act more rapidly than natural insulin. So again, you can modify insulin in two ways. You can simply modify the molecule, or you can add a protein to it. That changes its duration of action and how rapidly it kicks in. Now, natural insulin, when it's produced by the pancreas, looks something like this. It's a long polypeptide chain. Okay? The green portion of the curve is what's called a C-peptide chain. this C-peptide or connecting peptide is cleaved off of the molecule by enzymes within the pancreas, and that renders the remainder of the molecule the active form of insulin. Okay? So the original production is called proinsulin. Once that little C-peptide arm is cleaved off, then you have active insulin. Okay? Notice that active insulin is formed of a short peptide chain joined to a large peptide chain by 2 disulfide bonds. Now, this isn't the first time you've heard the term a disulfide bond. What other molecules have disulfide bonds? You've heard this before.
I'm picturing it in my head. I'm just trying to remember what it's
Immunoglobulins, antibodies. You remember that?
called. Yeah.
Antibodies are formed of 4 peptide chains, 2 long chains, 2 short chains, and are all linked together through disulfide bonds. Okay? You know, sometimes we'll see a new patient. One time I remember I had this patient who spoke very little English. Okay, he was from another country, had just moved to the U.S., and he had diabetes. And I was trying to determine whether he was type 1 or type 2. Okay, so I measured a C-peptide serum level. How would that help me in determining whether the patient had type 1 or type 2 diabetes?
If he has type 2, he's gonna have the cleavage up. He's gonna have a lot.
Well, he's going to have a lot of
Producing
C-peptide. He's going to have a lot of this. Why? Because the problem is not in production of insulin. The problem with a patient who has type 2 is insulin resistance. In fact, early on what happens is the pancreas produces more insulin than normal in an effort to try to overcome the resistance. So in that patient early on with type 2 insulin, they're going to have elevated C-peptide levels. Whereas if a patient has type 1 diabetes, are C-peptide levels going to be elevated? No, they're going to be low. They're not producing much insulin. So there's going to be a deficiency. So this is used clinically to differentiate 1 versus 2. Now the problem is that you'll have some patients who have had type 2 diabetes for a long time, and what happens is those beta cells of the pancreas begin to burn out. You know, they've been overproducing insulin, trying to overcome the resistance for such a long period of time that the cell then begins to burn out, and that over time then they also slow down their production of insulin. Okay? And so C-peptide levels in those patients may not be elevated.
So what would you do to distinguish the type 1 and type 2
So
in that
sometimes
case?
it's very difficult to distinguish
Okay.
if someone's got really long-standing diabetes.
Okay.
And that's a case where you can take a type 2 patient and treat them with insulin, because they truly are insulin deficient. But most type 2 are producing adequate insulin. Okay? We talked about the natural insulin that's derived from the pancreas, from the human pancreas. Okay? We could call that regular insulin. Okay? This is unmodified human insulin, regular insulin. It's available as a clear solution. It comes in a little vial. 100 units per milliliter. That's its concentration. So if it's available in a vial containing 100 units per milliliter, we call it U100 insulin. Now, some regular insulin is manufactured in a more concentrated form. Then it might be called U200 or U300 insulin, where there are more units per milliliter. But the most common type of insulin, the formulation is U100. And that reflects its concentration within that little clear solution. Okay. Now, Eli Lilly is a very big manufacturer of insulin. It reproduces regular insulin using recombinant DNA technology, and it calls its brand of regular insulin Humulin R. See, Humulin sounds like human. So this is human insulin R. It's the same thing as regular insulin that we've traditionally used. The other big company in terms of insulin production is Novo Nordisk. They call their brand of regular insulin Novolin R. So if you're looking at a physician's prescription or orders for insulin, sometimes you'll just put regular insulin, or sometimes you'll specify Humulin R or Novolin R. It's all the same thing. Okay? Now, regular insulin can be administered by 4 different routes. The most common route of administration is subcutaneously. A patient draws it up in a syringe and they inject it beneath their skin into the subcutaneous tissue. Regular insulin can also be administered subcutaneously via a pump. And in fact, we have a special guest here today who has an insulin pump. Jason?
He's like, what?
Is it Jason?
No, Chase.
Chase. Chase. Chase, just raise your hand. You may have seen Chase on TV. Probably a good chance that you have not. But later on in the class, Chase is going to demonstrate his insulin pump. So you can use regular insulin to fuel that pump. It injects a little bit of regular insulin into the subcutaneous space every minute. Okay? Now, regular insulin can also be administered IM, but that rarely ever occurs. And there's even an improved indication for oral inhalation, but very few, I've never known any patients that have done it this way. Now, for routine treatment of diabetes, you would inject regular insulin before a meal. Okay, it takes about 30 minutes, 15 to 30 minutes to kick in. So you would inject it about 15 to 30 minutes before the meal, and then it will cover your blood sugar. Meaning that it will facilitate movement of glucose into the cells for about 4 hours, or maybe a maximum of 6 hours following that meal. And so people who have brittle diabetes, they'll give themselves injections 3 times a day. 1 injection before breakfast, lunch, and then supper. Okay, and it'll cover the hyperglycemia, the increase in blood sugar that occurs following that particular meal. Okay. Of course, if you're using an insulin pump, that insulin pump can continuously infuse subcutaneous insulin to provide basal glucose control. That means a kind of continuous low level of control throughout the day. Now that person with the insulin pump is also going to want to take a bolus injection before each meal, because during those postprandial periods you'll have a bump up in the sugar level. Now, in patients who come into the emergency room with complications of diabetes, like we discussed last class, who come in with either diabetic ketoacidosis or hyperosmolar hyperglycemia, those people who have complications from type 2, okay? For those patients, we can also administer the insulin intravenously. We can administer it through an IV pump. Okay? For instance, a typical dose, intravenous dose, would be 0.1 unit per kilogram per hour. Okay? So if a patient weighed 70 kilograms, how much insulin would you administer per hour? So 0.1 times 70 is what? 7 units.
Oh.
Yeah,
So
they
you
do
set the pump to
decimal.
administer 7
Yeah.
units per hour. Okay? And then what happens is that patient comes in, that patient may come in with a blood sugar of 800 milligrams per deciliter. And so you'll start 7 units per hour. And then they'll come from, and you're monitoring their blood glucose levels every hour, let's say. And so they may drop down from 700 to 800, down to 600, then to 500, then to 400. Once you get below 300, you better cut off that pump, because that insulin hangs around. So you have to slow it down or stop the pump once they start to fall below about 300. Okay? Only short-acting insulins, like Humulin R, some of those even shorter-acting analogs, can be given IV. You can't give longer-acting insulin intravenously. Okay? I mentioned earlier an intermediate-acting insulin, NPH insulin. You said NPH is manufactured by conjugating regular insulin with protamine. Protamine is a large protein that changes the characteristics. It's hemodynamics. Okay? It decreases the solubility of the insulin and retards its absorption, so it's not as rapidly acting. Okay? But its duration of action is longer. We call it intermediate acting. Because we're combining it with this large protein, which affects its solubility, it comes in a vial with a cloudy suspension. It doesn't appear clear like regular insulin. Okay? And in fact, before you aspirate NPH insulin, you have to kind of agitate or shake up that little vial so that it's evenly distributed throughout the solution. Okay? Again, the two big insulin companies make forms of this intermediate acting insulin. Eli Lilly calls their brand Humulin N, whereas Novo Nordisk calls their brand Novolin N. So if you see an order either for NPH insulin, Humulin N, or Novolin N, it's all the same thing. It's an intermediate acting insulin. Doesn't kick in as quickly as regular insulin, but it lasts longer. Okay? So it's got a slower onset of action compared to regular insulin, but its duration of action is up to 16 to 24 hours. Okay? Compared to regular insulin, which has a maximal duration of 10, but it's really more like 4 to 6. Okay? The way you administer NPH insulin, or Novolin N, or Humulin N, is only subcutaneously. Okay? It is the only longer-acting insulin that can be mixed in the same syringe with the shorter-acting insulin. And when you draw them up into the same syringe, you always draw up the short